So let's move on with the case study. As you recall, our patient, 87-year-old, had hip replacement surgery. On postoperative day number 2, his hemoglobin drifted down to 8.3, was not symptomatic, but the nurse was concerned enough that he or she called the physician who was on call, and based upon that report of a hemoglobin of 8.3 on postoperative day number 2, that physician ordered 2 units of red cells. The first unit transfusion seemed to go okay, but during the second unit of transfusion, the patient became acutely short of breath, oxygen saturations dropped, and the rapid response team was called to the bedside, who saw him in acute respiratory distress and intubated him, sending him to the ICU. On the screen, you also see the chest x-ray that was taken at the time immediately before intubation, showing the lung findings. So based upon this series of events in this patient, what's the most likely cause of the respiratory decompensation? Is it myocardial ischemia? Is it acute respiratory distress? Is it transfusion-associated circulatory overload, also known as TACO, or transfusion-related acute lung injury? In this particular case, the most likely diagnosis is TACO, transfusion-associated circulatory overload. Trolley was certainly a possibility, but based upon the fact that this was in the face of a volume load in an at-risk patient and the fact that TACO is extraordinarily common, trolley is relatively rare, and the chest x-ray, as I said, TACO is the single most likely diagnosis. And we'll talk about in more detail exactly what is TACO. So in the back half of this presentation, we're going to delve into what's the science and the physiology of blood products that lines up with this literature that supports a more restrictive approach to transfusion. And I think it is important, although we've talked about levels of evidence and the scope and the amount of evidence, to understand the physiologic basis so that the pieces can come together, so to speak. So, as I mentioned, we know that anemia is harmful. We now have quite a bit of evidence that says that transfusions don't seem to make patients better, at least in that relevant range between 7 and 10. Well, why is that? Why don't patients get better with blood transfusions as we previously thought? The short answer, at least in a single visual, is this, is that although blood from the blood bank is a life-saving substance, I myself am a blood donor. I would certainly accept a transfusion if it was necessary. Blood from the blood bank is a very poor substitute compared to the blood that's currently in our veins. So there are significant physical properties that change when we store blood, and we'll talk about that under the concept of the blood storage lesion. And it's important to note, even up front, that blood from another patient is a transplant. This is a liquid transplant, and as such, there are a number of immunologic consequences that can also lead to downsides associated with blood transfusion. So again, blood from the blood bank is simply not an adequate or equivalent substitute for the blood that's currently in our veins, and that's the disconnect. So in this particular slide, which is pretty busy, I want to attempt to explain, at least at a high level, the basic concepts of what's called the blood storage lesion. And this goes along the lines of why is blood from the blood bank really a insufficient or unequal substitute for the blood that's in our veins. So the first thing to note is that when we store blood, typically we refrigerate it. We do not freeze it, although that can be done. It's fairly impractical on a large scale. So we refrigerate it. And the FDA says that we can refrigerate blood for up to 42 days. However, like anything else that we put in our refrigerator, there is some degradation of that substance as it sits on the shelf in the refrigerator. And red cells, again, are no exception. So the normal lifespan of a red cell in your body is about 120 days. The FDA says that we can store refrigerated blood in a preservative solution for up to 42 days. Functionally, what occurs during that storage cycle is red cells start to degrade in the bag. Some of the red cells are lost every single day, and by the end of that 42-day cycle, somewhere between 20 to 30% of the red cells are non-viable. The important part of that discussion isn't so much loss of available red cells, it's that as red cells break down in the bag, they release some fairly toxic byproducts that accumulate over time. Longer storage, more red cells degrade, more release of these degradation products. Collectively, we call these degradation products biological response mediators, and they include a number of complex things. Key among these are pro-inflammatory cytokines such as interleukin and tumor necrosis factor that accumulate over time as red cells are stored. Oddly enough, they can cause both systemic inflammation when they're transfused and may contribute to immunosuppression, which we'll talk about. Free pieces and parts of red cells as they start to degrade or release. These are called microparticles. These microparticles are very active and aggressive activators of the coagulation system. Again, conceptually, as our body sees parts and pieces of cells in circulation, it believes that there is trauma going on somewhere, and so it activates a coagulation process that can make patients hypercoagulable. In addition to that, we have plasma-free hemoglobin that's released from these red cells. Again, the amount increases over time, and plasma-free hemoglobin turns out to be a very efficient scrubber of nitric oxide, meaning that plasma-free hemoglobin from these transfusions will pull nitric oxide out of the system, which can then lead to systemic vasoconstriction, pulmonary vasoconstriction, and even microcapillary vasoconstriction. So again, these BRMs that accumulate over time can cause some downstream adverse events in our patients. In conjunction with this, which is perhaps even more visual, on the left-hand side of the slide, what you'll see is the morphology changes that red cells go through during their storage cycle. So normally red cells are stored at 37 degrees centigrade in your body. They have available to them nitric oxide, ADP, glucose, etc. But when we drop them into a cold storage solution, their ability to maintain that unique shape is greatly diminished. And so what happens, and it's again nicely illustrated here, is as red cells are stored, and it happens fairly quickly, they lose that unique shape and they start to become inflexible, sticky, and misshapen cells. In fact, medical technologists will talk about when they look under a microscope after someone has been transfused, what looks like sickle cell fragments show up on those blood smears. So the issue then becomes a mechanical issue on top of the BRMs, as that these inflexible sticky cells, some are cleared by the reticular endothelial system, others in fact have a hard time transiting the microcapillaries to be able to exchange oxygen, and it may take a period of 12 to 24 hours before the viable cells regenerate their glucose, ADP, etc., and regain that flexibility. So as I said, complex slide, but it tries to explain at a high level what are these physiologic differences in stored blood versus native blood, so to speak, that may account for this conservative versus liberal paradox for blood transfusion therapy. So with that basis, let's kind of get into lists here. So had I given this lecture 19 years ago, I would have started my lecture by talking about the infectious risks of blood transfusions, which it turns out to be are fairly minimal, although they are top of mind certainly for most of our patients. So the big concern, of course, in the 80s and 90s were HIV and, of course, hepatitis. as frequent as 1 in 1,000 transfusions. These are now 1 in a million to 1 in 2 million. Huge testament to the work of the blood industry through donor deferrals and donor screening. It turns out, and this is a trivia question, I guess, the most common transmissible disease is actually bacteria. And it turns out that that's in platelets. In fact, as much as 1 in 3,000 platelet transfusions contain bacteria that can lead to adverse events that include actually death. The reason behind this is that platelets do not function well when they are refrigerated, so we store them at room temperature. So even 1 or 2 bacteria from a contaminated skin draw can flourish over the course of that 3 to 5 days and then cause significant problems in our patient population. Beyond HIV, hepatitis, and bacteria, there's always something else that's out there, whether it's prions, West Nile disease, Zika, etc. In a mobile society, we'll never be risk-free because there's always going to be something else out there that may show up in the blood supply. But remember, on the grand scale of these are relatively minor. Where we need to focus is on the non-infectious risks of blood transfusion, things that I will just tell you I didn't learn much at all about in medical school or even residency, yet these non-infectious risks outweigh the infectious risks of transfusion by orders of magnitude. Number 1 on the list, and if there's nurses listening to this, you're well aware of this, are febrile and allergic reactions. They can occur between 1 to 2% of all transfusions. It's a bit higher if patients are chronically transfused, for example, cancer patients. Generally not major transfusion reactions, but certainly bothersome, and they can mask more serious reactions. We have to list for completeness hemolytic transfusion reactions, a dreaded complication where a patient gets a incompatible unit of blood that can lead to major adverse events or mortality. Turns out the number 1 cause of that incompatible transfusions is clerical error. At the bedside, typically, we see that this is not doing safety checks by nurses. And again, not blaming nurses here. I'm an anesthesiologist. We're subject to the same sort of problems. But I just want to point out here that human error is part of the chain of events in these types of transfusions. There is a growing number of acronyms associated with transfusion-related risks: transfusion-related iron overload, transfusion-related acute kidney injury, transfusion-related acute gut injury in neonates. There are immunologic consequences. We'll delve into that a little bit more, that include microchimerism. All red cells, even if they are leukoreduced, contain some white cells, and those white cells, if viable, can actually engraft in the recipient, which can lead to midterm and long-term problems, although relatively rare. And then pulmonary complications. For example, our case study had TACO, very, very common, but it could have been TRALE, at least that was in the differential diagnosis. Transfusion-related acute lung injury, probably 1 in 10,000. That risk has dropped substantially because about 10 years ago, the U.S. blood industry, following the European blood industry, started to remove female donors as plasma donors because of a higher antibody load. So let's talk a little bit more about TACO because it's germane to our case study. It's what, unfortunately, our elderly gentleman got. So the definition of TACO is evidence of circulatory overload within 6 hours of a transfusion. Typically, it's not going to take 6 hours to manifest it, but this is the consensus definition because TRALE also, there was a 6-hour window after transfusion to be counted as it. Clearly, you would typically also see some increases in CVP or wedge pressure, indicating that this is an overload, circulatory overload situation. And if you're trying to sort out TRALE versus TACO, as I mentioned, there may be some overlap. BNP may be helpful to distinguish that. The incidence is a little bit hard to nail down because this is grossly under-recognized and under-reported. 1 to 8% is what it shows up in the literature. We'll just call it, for the sake of argument, 3 to 5% as a kind of a mid-range. The mortality associated with TACO is not insignificant. It runs from 1 to 3%. And if you have a patient with any given diagnosis who gets TACO during their hospital stay, you have tripled their chances of dying during their hospital stay. Again, important to note here, it's not the TACO usually that kills patients. I mean, if you recognize it, you can treat it. It's the slippery slope. So a patient who is otherwise recovering gets, in some cases, an unnecessary transfusion or a transfusion given too quickly. That leads to volume overload, which leads to intubation, which leads to an ICU stay. And again, nothing good happens in the ICU. So it's a series of events that includes this volume overload that then lead to other adverse events, which ultimately end up being worse outcomes for our patients and certainly not desirable. As we wrap up the case study, we'll delve into that a little bit more. So who is at risk for TACO? Because I think this is an important part of it, is prevention, prevention, prevention. Pretty easy to think about and well documented. The extremes of age, again, the very young or the very old, patients who have positive fluid balance, and our case study was a setup because he had gotten quite a bit of fluids in the perisurgical period and was mobilizing those. Renal dysfunction turns out to be a huge risk factor, and he did have some minor renal dysfunction. There is a volume effect, clearly. So again, more transfusions mean more risk. Remember, it was the second transfusion that seemed to tip him over the line. And then an important thing, particularly for the nurses, listening to this presentation, is the rate of transfusion. Typically, it's associated with higher rates above 170 mLs per hour. One of the baseline issues here that contributes to this is, in many cases, nurses are not aware of what is an appropriate rate of administration for a high-risk patient, and they're typically not given direction either by the physician or, for that matter, by the American Association of Blood Banks in terms of what's an appropriate rate. So we believe a best practice is to have a default rate of administration that would keep patients out of general risk for TACO. And then if they are identified as being high risk based upon these criteria, that there are additional precautions layered in for nursing to be vigilant for this particular fairly high risk, high incidence, and high morbidity complication. So my comment here at the bottom, very sincere from a safety standpoint, is I think this is largely avoidable. I think in our lifetime, we can greatly reduce the incidence of TACO by making sure we only transfuse patients who need it, by giving them the minimum effective dose, and by working with our nursing colleagues to identify high-risk patients and be vigilant in terms of our administration rates and monitoring. Last major adverse event we're going to cover has to do with the impact on the immune function of patients. I previously said that blood isn't, in fact, a liquid transplant, and kind of an interesting tagline, but it's absolutely true. When we get a transfusion, it is a foreign tissue transplant, as if we were getting a kidney transplant or a liver, and we really should think along the same lines in terms of the due diligence and monitoring that we do. So when we do transfuse patients, there are a couple of things that are well documented and logical that happen to the immune system. The first thing that most people are aware of is it causes an antibody reaction because these are foreign proteins, and so patients generate antibodies against that transfusion. And understand, I'm A positive, and even if I get A positive blood, that's only a couple of the major histocompatibility antigens. Patients will have hundreds or thousands of foreign antigens that we can't possibly match in a standard transfusion. So I'm going to get, you would get, your mom would get these antibodies produced in response to this foreign transfusion. And the more transfusions, by the way, the more antibodies are produced, and it makes them harder to be able to get a compatible transfusion downstream. What is less obvious, but probably, honestly, more injurious to patients is what happens to cellular immunity. So very well documented, as patients get more and more foreign tissue, in this case a blood transfusion, you can monitor their immune system function, cellular function, declining. So more blood leads to more downregulation of natural killer cell activity, macrophage activity, etc., meaning they're becoming more and more immunosuppressed. Now, this may be adaptive, meaning that it may make them tolerate the transfusion, having this foreign tissue within them, but it's maladaptive because as their immune system gets downregulated, they become more susceptible to adverse events, and that's kind of the second part of the story. So as patients become more exposed to foreign proteins, more transfusions, there is a dose-dependent reduction in their ability to deal with foreign invaders, so to speak. So this dose-dependent immunosuppression is probably one of the most significant things that we need to be aware of as we make transfusion risk and benefit decisions. So clearly documented in the literature, and I've just given you the underpinnings of the physiologic basis, is when patients get more blood products, they tend to get more hospital-acquired infections in both medical and surgical patients. So there's an argument here that appropriate blood use should be part of good infection control processes within hospitals. We also know that morbidity and mortality in general increases, likely a combination of these immunosuppressive effects as well as the susceptibility to infections. And I think equally concerning for cancer patients, because of this reduction in their immune competence, patients who get blood transfusions are more likely to get cancer recurrences as well. All that being said, and as alarming as that is, I want to emphasize is we still need to give cancer patients blood. We still need to give cardiac surgery patients blood. We still need to give GI bleed patients blood. We don't have any other substitutes, but we need to be very thoughtful, judicious, evidence-based when we do make this transfusion decision because, again, this is a liquid transplant that we're delivering. The final major concept to explore that I think brings all of this together is the concept of the dose-response curve, which follows, I believe, all the conversations we've had about the blood storage lesion, progressive downregulation, etc. So first of all, many physicians, at least in the past, discounted the adverse effects of transfusions as correlation, not causation. Older, sicker patients get more blood, so they have adverse events. Again, we've shown that not to be true. The second misconception is that adverse events only occur in multiply transfused patients who, again, may be different patients to begin with. What's very clear in the medical literature, and I think extraordinarily well defined in the surgical literature based upon a very large data set from the National Surgical Quality Improvement Program at NSQIP data set, show that transfusion adverse events are first and foremost dose dependent, meaning more blood, more adverse events, and that harm begins with a single transfusion. Very important, single transfusion. So most of the data, for example, in a surgical data set, is not with patients that have gotten 8 or 9 or 10 transfusions. It's patients who have either gotten 1 unit, 2 units, or 0 units, and they show consistently there is a difference in outcomes. So even that first unit is an important unit to consider risks, benefits, alternatives, and dosing. And then, as I would say for my trauma colleagues, cardiac surgery colleagues, OB hemorrhage colleagues, it's not about eliminating transfusions. It's marginally reducing even a single unit or two during the care of the patient. So again, our goal is not to eliminate all transfusions, but to marginally reduce transfusion exposure from 5 to 4, 4 to 3, 3 to 2, etc. So the dose-response curve, I think, is an incredibly important concept to sort of burnish in your mind when we consider transfusion therapy. So let's wrap up the case study now. and let's talk about this particular patient. So as you recall, had surgery, got transfusions postoperatively for a drop in his hemoglobin, got TACO. The patient was fortunately extubated after 2 days in the ICU, but unfortunately, during his ICU stay, he developed deep venous thrombosis, which then required short-term bridging and long-term anticoagulation. He ended up spending 3 days in the ICU and a total of 10 days in the hospital. Just for comparison, typically this patient would have spent 2 to 3 days max in the hospital and would have gone home. Instead, again, 10 days in the hospital, including the ICU. And unfortunately, instead of going back to his home, which is where he wanted to go and his family wanted him to go, he ended up being discharged to a rehab facility for a period of 2.5 weeks. So the final case study question is this: what were the contributing factors to the patient's postoperative complications and prolonged care? And I think we'd all agree if this was our dad, grandfather, uncle, we certainly would not have chosen this particular course postoperatively. So A, decision to transfuse at 8.3, B, failure to address preoperative anemia, C, decision to transfuse 2 units, and that's versus 1. Potentially, inappropriate transfusion administration rate. Well, I'm going to make this one hopefully easy, and you've already gone there. The answer is G. The answer is all the above. And the final commentary here, and the reason that I have a case study worked into this lecture on what is the evidence for conservative transfusion practice, is I want to emphasize that appropriate patient care, and in this case, appropriate blood use, is a team sport and needs to be proactive. It is incredibly important that our physicians and advanced practice providers make the right decision to give the right blood product in the right dose at the right time. But in cases like this, which are pretty typical, it's actually a continuum of care that needs to be optimized because that's what we'd want for ourselves or our family members. So the failure to address his anemia preoperatively certainly contributed to this. That transfusion decision, which I think was unwarranted, not just in terms of the level, but in terms of the dosing, all of these things eventually led to adverse events that I believe were preventable. So again, the final word here, as I said, is appropriate transfusion practice goes above and beyond evidence-based practice. It has to do with proactive, thoughtful management during the care continuum by a large number of people that includes physicians, pharmacists, nurses, laboratory technicians, and of course, families and patients as well. So I thank you for your attention and would certainly look forward and welcome comments or questions. Thanks so much.